Hi, everyone, and welcome back to another and our final episode of this season of From Print to Pod. We have with us Dr. Noemi Adame, who is coming back to join us. She joined in a previous episode for the article that we published called Fast RX Boundaries for Women Leaders. Welcome, Dr. Adame.
Oh, I'm super glad to be here, like always. Thank you.
Of course. Okay, let's get right to it and ask you the questions that we have set up. The first
Uh-huh.
is the following. You open by naming the invisible labor many female physicians carry. Was there a moment in your own practice when you realized this wasn't just fatigue, but something structural and gendered?
Yes, I think there have been many, many moments that led up to this aha realization of, my goodness, it's not just me. There's this is a systemic issue that affects female physicians across multiple specialties, across multiple generations. Because at first I thought maybe it was like a generational thing, and I think that the moment that I think I've talked about it before is when my mother died. And she had a stroke, was in the ICU for 6 days before she finally succumbed, and I was in the ICU sitting there watching her die with a computer on my lap, answering texts, filling prescriptions. At one point, did some telehealth from the hospital bathroom. And when I was processing and in the aftermath of all that trauma is when I realized, okay, this has got to stop, first of all. Um, and this cannot just be a me issue, right? This has to have been some sort of systemic issue. And so that was really the turning point for me. That was really the one. Yes, there's a lot of little moments from when I was a resident up until in every environment in which I've worked, as a resident in the hospital, as a resident in the clinic, as a hospitalist, as a physician in outpatient based world. There were many, many moments that led up to that realization that yes, there's systemic and gendered issues that affect female physicians, and how much work we put in. But that was definitely the pinnacle. And then of course, as I was an academic for a long time, and you can take the girl out of academics but not the academics out of the girl. With that very emotional and visceral experience, I did a lot of investigating and reading, and came across so much data that shows, first of all, that female physicians do have better outcomes when it comes to patient care, right? Absolutely mad respect for my male colleagues, but the data is very clear on that. And number two, the reason we have better outcomes is because we do things like spend more time with patients, listen more, interrupt less, are more likely to adhere to clinical practice guidelines. But the current system does not reward that type of practicing medicine. And of course, because we have external pressures, patients demand more from us, staff demand more from us, our colleagues and our communities demand more from female physicians than they do male physicians. All of that takes a big, big toll on our health, on our well-being. And while boundaries are important for everyone, this is why it is especially important for female physicians. And it is especially important, and this is the world that I currently am in, is the DPC, the direct primary care world, because it is a very relationship intensive system. And there's very little buffer between the patient and the doctor. So it's important that for us to be healthy and provide sustainable care long term and prevent compassion fatigue, we have to have these boundaries. So that was a very, very circuitous, I think, answer to your question.
No, it made complete sense. I was actually going to
Yeah.
ask you about private practice,
Mm.
following what you were saying, and then you went into the fact that you went into private practice. It does
Yeah.
make sense that you would have um, more face time with patients when you're in charge, but also you are able to sort of establish the rules because you're the
Mhm.
boss.
Right, right, right. Yeah.
So
Mhm.
you draw a sharp distinction between rules and boundaries. Why do you think so many physicians default to rules even when they don't actually protect us?
I think it's part of the part of the way the system works, right? The system works in a very it's not relationship driven. It is not caring, and it is very legalistic. So because of that, it's we have very set rules, and even simple things like office hours are blah blah. If you need to contact someone, use the portal messages. So the system itself is very rule oriented, right? And rules for patients. Um, when we go into the DPC world, that changes a little bit because there's just so much. There's because of the access, right? Especially access and convenience being such a big part of why people gravitate towards direct primary care practice. And one of the things that is so important in this very relationship intensive model is that we have to preserve the sanctity of that relationship in a way that doesn't create this paternalistic type of situation. So that's why it's so important to distinguish between rules and boundaries. And the classic example I give for DPC docs is, and first of all, to distinguish, rules are externally imposed. They're a lot of times arbitrary, right? Like office hours, and they can feel punitive. And the reason they feel punitive is because they attempt to control other people's behavior. Boundaries, on the other hand, are internally guided. They're rooted in values. They are about managing your own or my own behavior, not others. And the classic example that I always give in the DPC world is, because patients can text us or send us messages directly, is the texting, right? Texting boundaries or texting rules. A rule is don't text me after 5 p.m., right? It feels punitive because let's say that a patient does, for whatever reason, right? Because they're asking for a refill, they're asking for advice, and they do have to text you after 5 p.m. Even if they don't expect a response at that time, they're going to feel like, oh my goodness, is she going to punish me? Is she going to get mad at me? Is she going to wag her finger at me? Is she going to dismiss me from the practice if I break this rule? So rules just create this awkward, paternalistic, not the soft cozy relationship we actually expect in DPC. Boundaries, on the other hand, the boundary in that scenario would be, I respond to after hour texts the following morning. So there's just this big difference, and it creates a very different dynamic and a very different relationship. So in that scenario, the patient can text at 5 6. I have college kids. I have a lot of college kids in my practice, and I get a lot of refill requests on a Friday night, Friday at 10 11 midnight, for ADHD med refills. And I don't go back and wag my finger at them or tell them don't text me after it's not appropriate to text me at midnight for a refill request. Patients can text me at any time, but I am going to respond within the boundaries that I have set. So that's the main difference between a rule and a boundary. And I have found that trying to enforce rules, in other words, trying to manage other people's behavior, is exhaustive. It just leads to exhaustion and compassion fatigue and decision making fatigue, and you feel like you're always either arguing or correcting people, and it just does not create a good relationship. Whereas a boundary is a lot less exhaustive because it's my behavior that I'm managing, not other people's behavior.
Yeah, yeah, that makes complete sense, especially with the need to form boundaries.
Right.
You wrote about the FAST framework in your
Mhm.
article and how it feels practical, but is also values driven. Which
Mhm.
step was hardest for you to adopt in real life and not just in theory?
The hardest one was actually the last one, tell the truth. And it still is. So the fast approach to boundaries stands for F is fair. You know, is it, you ask yourself, is this fair? A is no apology. S is stick to your values, and T is tell the truth. And telling the truth has been the hardest for me, is the hardest for me to apply, not because I want to lie, but because people react very different to the truth, and sometimes it is hard to predict. We actually had a really good discussion about this. I held a DPC women's retreat last year that we're doing again this, or actually in 2025, and we're doing it again in 2026. But with the classic example that came up during that time is when we're not available, okay, for whatever reason, right? Whether it's for an appointment request, whether it's to give advice, whether it's to send a refill, a prescription, for whatever reason. Let's say that we are just not in a position to respond. How much truth or reason we give patients or staff about why we're not available is very dependent on who's on the receiving end. For example, if most in the DPC world, most patients, if you tell them, I am not available to see you today, or to send this refill because I am on a at a soccer game for my child. You know, that was one of the examples. You know, I'm at a soccer game for my child. I don't have access to my computer, so I won't be able to fulfill your request or answer your question, or, you know, access your child's chart until tomorrow or later tonight or whatever. You know, some people respond to their doctor being human and vulnerable, and with that level of honesty, very positively. And will react like, oh yeah, of course, yeah, you're a human. You have children, you have a life. You eat, you shower, you work out. You have a dog that you take on long walks, right? You know, and that's a big one for me. You know, especially during the summer, I take my dog on long walks, and I don't take my phone with me. So if I were to come back and, you know, get a text and respond with, oh, I was on a long walk with my dog, or, you know, again with people, young children, I was at a soccer game. Some patients respond that very positively, like, oh, my doctor's a human, but others do not. Others do not. I have had, you know, one, you know, that prominently sticks to my mind, that reacted with severe hostility with that level of honesty and telling the truth and vulnerability. That person is no longer in my practice, you know, and that happens, and that's okay. That is not, I did not consider that a loss when that person left my practice. But it just made me realize that I have to be very careful, and everybody has to be very careful with how honest are we, to explain our boundaries. You know, like, I can't respond because of this. And everybody it can have can kind of gauge and check the temperature for their own relationships and patient relationships, and they might be different even within the same practice. But that is what I have struggled with the most, because I want to be honest, and actually my default is to over explain, and I over explain not to give excuses, but because I want to be transparent and I want to be human. But sometimes it backfires. So I think that's the one that I've struggled with the most.
Yeah, and actually, the next question deals with that because you do
Mhm.
write about the subtle power shift that happens when physicians over apologize. So,
Mhm.
how did changing your language from apology to gratitude change how
Mhm.
patients responded to you?
So I think it changed in a very positive way, because we also had a big discussion about this during the retreat. The classic example I give in that case is if you're running late. right? Which happens. And now, mind you, when I was in corporate medicine, running late meant an hour. Right? It was totally different. In my DPC practice, 5 minutes is running late. So it is, but the expectations are also different, right? In the corporate world, patients were so defeated. Like they're waiting an hour for the doctor was almost like expected. In my DPC practice, 2 or 3 minutes. If I haven't started the appointment in 2 or 3 minutes, whether it's in person or telehealth, my patients are sending messages like, "Hey, I thought where's the link?" Or so it is a different expectation. But when I do, if I am running a few minutes behind schedule, which rarely happens, but sometimes it does, instead of saying, "I'm sorry I'm late," I say, "Thank you so much for waiting." And that also creates a very different relationship dynamic because a lot of people interpret "I'm sorry" as you're admitting that you did something wrong. You're admitting guilt. And again, it varies depending on the mileage varies depending on who the patient is, right? And what the relationship is. Whereas when I say "thank you for waiting," I acknowledge that I value their time. I acknowledge that yes, the meeting did not start at the appointment that was expected, but I don't give up my power. I don't give that opportunity of admitting guilt over something that really a lot of times is beyond my control, right? And it's I don't run late because I'm on my desk eating bonbons. It's usually because the last patient needed me longer than I anticipated. And that's usually the reason that I'm running late is because the previous patient needed me longer than I needed. And so I just feel like that that is not something that necessarily warrants an apology. And by showing gratitude, "Thank you so much for waiting," I think that sets a very different tone than "I'm sorry." What sparked discussion when we discussed this at the retreat was some of the other DPC docs felt like "I'm sorry" isn't necessarily an admission of guilt, but it's basically acknowledging that you appreciate that person, or that you feel for them, or empathy. And the example they gave was when someone dies, we often say, "I'm sorry for your loss." And, we're not saying, "Oh, your loss was my fault," right? But you're acknowledging, you're giving empathy and sympathy. So it is one of those situations where each doctor knows their own patients, knows their own practice, and they can determine where what they feel comfortable with. I have found I feel more comfortable when I show gratitude instead of saying "I'm sorry," because it's been such a big mindset and in mindset shift, and it's helped me a lot, and I feel like it's helped my relationship with my patients.
Okay, makes complete sense. And this is probably a good time to add before our last question that Dr. Adame is going to be speaking actually for our second annual
Mhm.
Lifestyle Medicine Conference, which is online and is free while is live. Her
Mhm.
talk is going to be called Nourishing the Mind, Body, Spirit
Mhm.
of Neurodivergent Patients Through Lifestyle Medicine. So we're very excited about you delivering that talk.
Yeah, I'm excited too. It's a big part of my practice is neurodivergent children, so I'm very, very excited to talk about it.
Very good. And now for that question, you note the same boundary can be received very differently depending on the physician's gender. Just to bring the
Mhm.
gender issue back full circle, how
Right.
should women physicians think about fairness when they're navigating systems that don't always respond fairly to them?
Right. So, and it's interesting because I cannot control the system. The system is inherently unfair to female doctors because it rewards a volume based approach to practice instead of a quality approach to practice. And so the system is inherently unfair to the way female doctors practice. Which explains a lot of things, right? The higher burnout rates, the lower pay. It explains a lot of metrics, that we would use to measure fairness. Um, And for me, the really what has helped a lot is, first of all, I cannot control the system. I have no power to control the system, change the system. And as much as we can talk about it, the fact is the system is a system, and there's very little we can do to change unless literally every single doctor walked out tomorrow and said, I'm done with you. That is really the only way that the system is going to change. But until all of us develop the guts to do that, it's not. Um, but in my own practice, I am the system. I can make changes. I can either leverage tech to be able to set sustainable systems, sustainable practices, and that are fair. The big example that I'm going to give when it comes to fairness for female physicians, one of the things that's so important to prevent compassion fatigue, to ensure fairness, is prevention, right? I'm a primary care doc, right? So instead of constantly having to enforce rules and boundaries, is having the system already set up so it's fair. So for example, one way that I have done that is self-scheduling. And I know self-scheduling is very controversial in the DPC world. Some people are like, no, I want to have more control. But thank goodness, with my EMR, I use Sigma MD. I am able to set my schedule down to the hour, and what appointments can be and for how long, down to each hour of the day. So that gives me a really good control over my schedule while allowing self-scheduling. And the reason self-scheduling has been such a game changer when it comes to fairness is because when it was either me or my staff trying to schedule patients, there were moments where patients did push what was fair. Well, can you do a routine, wellness physical on a Saturday so that I don't miss work and my kid doesn't miss school? And we would offer evening appointments. Well, no, but they have sports, and so it just felt like, okay, so this person is asking me to give up more than what they're willing to give up themselves for their own child's care, right? So that mindset change of, wait, is this fair? No, it's not, but it still was really hard for me and my staff, even though it wasn't fair, what that person was asking wasn't fair, to say no, right? So I ended up doing wellness appointments on a Saturday when I was giving up more than that person. So when we went to self-scheduling, oh my goodness, it was such a game changer, because you can try and negotiate with a person, you cannot negotiate with an online calendar. So it just really reduced our stress level, our decision-making fatigue, our burnout, when we went to self-scheduling. And I won't go back. I really feel like, and so that's where fairness is not just about constantly, enforcing, because that is tiresome, but creating systems that are fair so that they prevent that pushing, that pushing of the boundary.
Okay, very good. Thank you for that. And it's so interesting because we recently partnered with Dr. Ava from Instagram on boundaries. We actually created a long sleeved shirt that says "Boundaries Save Lives." So I think
Yeah.
it's so relevant because so many more of us talk about and think about boundaries than people may know.
Mhm.
Thank you so much, Dr. Adame, for joining us. I wish you luck on the retreat that's coming up. Guys, check that out. And we also look forward to you speaking with us at the Lifestyle Medicine Conference. So thank you
Yay.
for being with us.
Yeah, no, thank you.